ready for another student webinar? We're already on number 36. A really unique question came into the CCO club that made me think that we need to do a little bit of extra training in a topic of lithotripsy, but I thought I would share also how I do research and some things that you need to know, not for testing, but when we start thinking of real world coding. All right. Now, as a student, right, your main goal is, hey, I got to pass that test. Right? But we want to make sure that you understand how to get out there, find information, because it's not just about passing the exam. You want to be able to, after you get that job, that first job, to hit the ground running. And you're going to run into stuff all the time that's going to throw you for a loop that you maybe don't know where to find the code for, whether it be CPT, ICD, whether it's PCS, or anything, even HCPCS. So this particular topic that came in was lithotripsy, and they wanted to confirm what code to use. Oh, let me go back one more. And for the most part, especially for testing purposes, if you get a question on lithotripsy, then you're going to be, it's going to be regarding the kidneys, because really the most common thing that lithotripsy is used for is to bust up a stone, usually or it's called a calculi, and they're usually calcium, but it doesn't always have to be calcium. Stone that gets caught in the kidney or between the kidney and the bladder, so the ureter, it would get caught in the ureter, causes severe pain. Most of the time, people that get kidney stones can kind of pass them on their own, drink lots of water, and they get pain medication and stuff. But sometimes they get stuck, and so they'll go in and try to find it and pull it out, or they'll do lithotripsy, which is a shock wave type of treatment. So again, whenever you hear or think of lithotripsy, then it's usually involves the urinary tract in some way. It would be a good idea, if you're not familiar with lithotripsy and the treatments that involved with those with the kidneys and stuff, that you go out and do a little extra study. Maybe go look at a procedure, go to YouTube and see, just put in lithotripsy and you're going to get tons of videos on how it's done, when it's done. You can go to Mayo Clinic and find, and just type in lithotripsy and it's going to bring up kidney issues. You can do it on WebMD, but I like Mayo Clinic because what Mayo does is gives you education as if you were the patient. WebMD does too, but to me, I like the format that Mayo Clinic uses. That all being said, this particular question came in about coding lithotripsy, but it wasn't for the kidneys. It was a vascular lithotripsy. Now, if it's a vascular lithotripsy, that means it's doing the shock wave, which is lithotripsy, in a vein. Or if it's cardiovascular, then it's doing vein or artery or something like that. So very, very interesting. Now, I've heard of that being done before, and but it's just not something that was on my radar, because again, usually questions that come in with lithotripsy is all about the kidneys, and I know how to code that. It's just a handful of codes. So what I want to do first is look at those codes. Okay. I didn't really prepare a lot of stuff for us to look at as far as how lithotripsy is done, when lithotripsy is done. Now, I've had lots and lots of kidney stones. And I've had procedures and I've never had lithotripsy because they were always too small. So I was told back in the day when I had to go in and have surgery where they just kind of went in and to go get one, and they go through the urinary system, they, you know, if it's really big stone, they can go in straight into the kidney and literally cut it out that way. Okay, now that's a really big stone. But if it's a little bit bigger than, if it's, I think it's 6 millimeters or 7 millimeters, but 6 millimeters. So think of the little beads, like if you're making jewelry or something, a millimeter bead, how small that is. The biggest stone that I'm aware of that I had was a 5 millimeter, and I thought I was dying. So bigger than that, then they would do lithotripsy, but mine at 5 millimeters wasn't a candidate to do that. Now, there's criteria for that. I can't tell you what the criteria is. You can go out and research it. It would be a good idea. Then you can also, like I said, watch videos, see how lithotripsy is done. They ultimately, a lot of times, will put you in a bath of water and it zaps it because it's a shock wave and everything. And that's important for you to understand and know how to do, you know, how it's done, because whenever you are unfamiliar with how a procedure is done or a disease process, then when you learn about that, that makes you a better coder all around. Okay, because you understand the verbiage that's being used, and you can almost picture the procedures being done in your head. So we're not going to do that because you can easily check that on your own. Let's look at how to code a regular lithotripsy of the kidneys. Then I'm going to show you how I educated myself on doing lithotripsy for the cardiovascular system. And I bet you're thinking, I didn't even know you could do that. So the first thing I'm going to do is just bring over here, find a code, and then we would use the index. So the click index is just an index search. And we're going to look at CPT because we'll do a CPT procedure. Okay, so this is if you're following along and you've got your manual with us, just pull out your CPT manual and bring in the index, and then let's just put in lithotripsy. Okay, now look at, I didn't even have to spell it all out. Lithotripsy, here are our code ranges that are going to, you know, advise us. Now, 00 codes are anesthesia codes, and you may be coding anesthesia for lithotripsy. So that's going to be a code range of 00872 through 00873. We'll go look at those in here in just a moment, okay? Then notice we have two codes, 50080 through 50081, two codes. Now that tells us that that's two specific codes. They classify that as a range. Okay, so we'll look at those in a minute. And then we're going to look at 50590 and 52353. And we need to know what the differences in these codes are. So let's start with anesthesia. If we're going to code anesthesia, meaning you're coding for the anesthesiologist, you're not coding the procedure, you're coding for the anesthesia for the procedure, or if anything is done for that. So let's just go grab that code range. Let's look at it first. And hopefully my internet will be fine. I could have pulled these up. While they're doing that, I'm going to go ahead and pull these other ones up. The most common, again, reason that lithotripsy is going to be done is for a kidney stone in the kidneys. And I think just for a second, guys, I'm going to take my camera off. And it should make these, I'll put my camera back on in just a moment. But I want to do that so this will load faster. So look at 00872, anesthesia for lithotripsy, extracorporeal, which that just means from the outside of the body when you see extracorporeal. Shockwave with a water bath. Now, real quick, if you're going to do the BAT technique, which we encourage you to do, you're going to highlight with bath water or water bath, and then lithotripsy extracorporeal shockwave. Okay, now remember there was more than one code, so let's look at what our codes were. Our other option is without a water bath. Simple as that. Okay, so that's the anesthesia for those codes. All right. This came up, so let me put my camera back on. All right, so next is a code range for not anesthesia, the procedure itself, or the op report or the procedure report. Endoscopic, retrograde. Now, look at this really big word right here. This is a let's see, pancreatography. I could put my fancy readers on if I need to be able to see. Yeah, that's what it is. ERCP. Nobody is going to say that word. They're just going to say ERCP is what that is. Okay, so if the BAT technique was done here, this would all be highlighted. And then this ERCP would be underlined. Okay, so we're going to go in endoscopically. We are not visualizing anything. It's endoscopic. And they're going to destroy the stone. Okay, that's what we're doing. That's why we're doing it. But notice here, any method. So that means they can use mechanical, electrohydraulic, or lithotripsy. So this is a catch-all code, what I call catch-all codes. Now, again, if you want more information about how that's done, here we go, and where it's done at. This is biliary and pancreatic ducts. Now, this is not the kidneys. Biliary and pancreatic duct. If you don't know where that is, let me just show you in this image real quick. What happens is wherever you can develop stones or wherever there's a lumen or a duct, you could get a stone. So see this right here? This right here is the gallbladder. This is the pancreas, and those spill out. They have these ducts right here. So this is the pancreatic duct right here. This duct that spills into the small intestine, and that's where we absorb our food. But right here, a stone gets caught right there. Okay, you can get a stone up here for the gallbladder, all different places. But so what they're saying is, whenever you're going to do it for the pancreatic or a gallbladder, then, and it doesn't matter how you do it, and lithotripsy's in there, you're going to use this code. Now let's look at the code range for that though. What are our options? Look at all of the options. Here's our first choice, which, remember, any method. Then we start looking at other body areas, and lithotripsy is not listed on these. Nope, because these are actually in the code range. If you're looking around there, that is for going in and looking at something. All right. Now, and look, it says removal of a foreign body. That is not, it's a calculi see, it's a calculi on this. That's what determines and makes that different. Now, let's look at the, that was 43265. Now we're going to go to that 50080 code. Let's see if it's faster if I just hit this. Uro, right? Now we're into the kidneys and stuff. Let's see, ureteroenterostomy, direct anastomosis of ureter to intestine. Now, again, that is, if they do a lithotripsy with that, maybe, but that's, lithotripsy isn't even mentioned, is it? And A1, let me just hit the range. These were all found under lithotripsy. 80181. Was it 10 or 01? No. Oh, I did it wrong. Sorry, hold on. Wonder why that didn't look good. 50080. It's a little dyslexic there, huh? All right, lithotripsy again, right here, lithotripsy. Percutaneous, okay. Now, if it's percutaneous endoscopic, that means we're visualizing something. So percutaneous, and this is a nephrolithotomy or pileo lithotomy with or without dilation. Okay, so that's not, we don't care about that. Endoscopy, lithotripsy, stenting, or basket extraction up to 2 centimeters, meaning there is a up to 2 centimeter stone. If the difference is if the calculi is over 2 centimeters, then you're going to use 50081. Now, this is what I had done because I had a 5 millimeter stone caught. Now, nephro is the kidney, pileo. Let's look at the anatomy of the kidney to determine which is the proper code. And you have, so again, you got to know the anatomy. So this is nephro, would be this part, it's stuck right here in the kidney. And then if it, I don't know if they're going to show us a picture of this or not. Let me see if this one does. Pileo, no, okay. But if it's starting to come out, then we have that other code. All right, so that's those 2 codes right here. Then we have 2 other codes. Now I'm not even going to try. Let's see if I can do this. If it's going to take too long. 50590. While that's doing that, I'm going to put in 52353. Is that right? Man, later in the evening I can't. 52353. Yeah. All right. So, cysto, let's see, cystourethoscopy and ureter. So now we're doing the ureters and the bladder. Cysto is the bladder, and or pileoscopy with lithotripsy, and the catheterization is included. All right, very, very specific. If you don't know how that's done, it gives you that in Find a Code. And again, we're doing a stone in the bladder or in the ureter or piloscopy, just like the other one. However, what did this code tell us? 5059. Lithotripsy, extracorporeal shockwave, just the lithotripsy by itself. And it's abbreviated ESWL. So if you see that ESWL, and that's all they're doing, it's kind of a catch-all, right? 50590. So they use that one a lot. Okay, now that all being said, now we know the lithotripsy for the kidneys. When we put in lithotripsy, did any of those cover cardiovascular? No, they do not. Right? So look, this one though, this is lithotripsy, extracorporeal shock wave, right? So that means from the outside of the body, they are doing a shock wave outside of the body. That's pertinent when we get into cardiovascular lithotripsy, right? So remember that. All right, now what I want to do is get rid of these. I'm going to just put this over here to the side. That's why I said, like, it's you know, the kidneys, pretty straightforward, easy to find, whether you're doing anesthesia or you're going to be doing the, you know, we need to know where the stone is. Is it in the kidneys? Is it in the ureter? Is it in the bladder? Is it in the urethra? Which it probably isn't going to be in the urethra. But we need to know the location. Is it in a biliary duct? Is it in other words, it is in the upper abdomen? Okay, so those are reasons why they would do a lithotripsy. You're going to go out and do your homework by understanding how the lithotripsy process. Notice that that first code that we looked at was with or without a water bath. And again, what they do is they submerge you a little bit in this tub, this metal tub with water in it, so that it carries those shock waves. But it is a shock wave that breaks up the stones. And don't think that it would like hurt your bones and stuff like that. No, it's a directed shock wave. Okay, not just for the kidneys. Now, everything that we've looked at so far has not given us a clue as to what code we would use for a cardiovascular lithotripsy. And I suspect that it's because you didn't know that it existed. Noah says, oh, I had one that wasn't treated with anything but painkillers, and I thought my ureter was being cut open with a knife. It was the worst pain. Yeah. Oh, and another thing, when you read the signs and symptoms, go and read the signs and symptoms of a kidney stone. They will call it colic, nephrological colic, I think is how they say that. What happens is it's ongoing pain, but have you ever had a stone bruise on your foot, or you stepped on a rock? Have you ever stepped on a Lego in your kids, you know, when you're walking across the floor barefoot? Think of that pain, but it doesn't ever go away, and it gets worse. So some of the signs and symptoms is flank pain. You can run a fever, but you know, mostly a nausea, vomiting, because the vagus nerve also goes down through there and it triggers that vagus nerve. So a lot of people throw up, which that's what I was doing. I couldn't stop throwing up, even after they gave me all that medication. So for documentation purposes, for you being able to abstract to the highest specificity and stuff, it behooves you to understand how lithotripsy is done. Okay, so you're going to go do the research on that, watch a video or something on YouTube. It'll be very interesting. Second, you need to understand why you would do lithotripsy. So again, usually it's some type of a calculi in the urinary tract, but it could be in the abdomen, in a biliary tract, coming from the pancreas duct or the gallbladder, the ducts there, you can develop stones. Okay, but now you know a third reason, which would be there, can you develop a stone in the cardiovascular system? Well, the answer is no, not really. What happens in the cardiovascular system is that you build up plaque. Now, let's show you how we do the research to figure out how we're going to code a procedure that technically really doesn't have a code, okay? That we know of. We don't know where to look. So the first thing that I did was I went and I Googled shockwave lithotripsy cardiovascular, or cardiovascular lithotripsy. Okay, that got me a few things. And then I realized, oh, you know what? This is probably not being done in the US, or hasn't been done in the US very long. And sure enough, so this is what I found. This document. Okay, here we go. And I put these links for you, so everybody, all of our students, you'll be able to have these links, okay? This came out in 2018. Now, one of the things that you need to know about research is that you want to make sure that you're getting it from a reputable site. So this site is the DAIC, which is Diagnostic and Interventional Cardiology. All right. I would say that that's a top-notch place. This particular article was written by a doctor, an MD. All right, so we can trust what they're saying. Intravascular lithotripsy may offer solution for calcified coronary lesions. Now, we already know that lithotripsy is used for calculi, which is usually made up of calcium. Okay, not all of them are, but they're probably a high percentage. So I don't know what that percentage is. I'd be just talking out of the side of my mouth if I said, 75% of all are calcium. Well, there is a statistic out there, and I just happen to know that most of them are. I just don't know what that percentage is, but that doesn't matter to us. The key is, if lithotripsy can bust up a stone in the abdomen, in like a biliary duct, and a kidney in that particular, in the urinary system, okay, it busts up calcium. If you have calcification in the vascular system, the coronary vascular system, then it should work for that as well, right? Because it obviously busts up calcium. Now, busting up a stone for in the abdomen, or in, in a duct, and also the urinary system, it is not going to obstruct something after it's busted up as it goes out, right? Because it's going to leave the body, right? It's going to become dust, and the body can process that. You can't do that in the vascular system now, can you? Because what does the vascular system do? It gets smaller and smaller, and then it goes into the rest of it, then it goes into arteries. So we have our arteries, we have our arterioles, capillaries, venules, veins, heart, lungs, and then the process starts over again. And we don't want any blockage in there. We don't want anything floating out. There is no way to expel that through the body. Okay. So the thought of just, in what limited knowledge I have, I'm thinking, how are you going to bust up calcium or some kind of a stone and it not affect, where's it going to go, right? So they have to have cured that or fixed that. But the fact that they're doing this is key for you in your research. Look down here. Over the last decade, there's been considerable development in procedural technology facilitating the treatment of complex coronary artery disease, CAD. All right, so just in the last decade, which is not very long, the last 10 years, they've been doing this advanced treatment on how to treat CKD. And complex coronary artery disease means that you have that hardening of the arteries. How does it harden? It gets plaque and calcium buildup. That's what it is. All right, and other things. So what they had done, and notice this is complex CAD. That's different than just having coronary artery disease. And I'm not going to go into the diagnosis coding, but that's what I love. I'm into that diagnosis, ICD and stuff. But just let me tell you that complex CAD is literally more complex than having CAD. So for only complex CAD. All right, now let's jump around here. However, percutaneous coronary interventions, PCI, which we do already, of these calcified lesions, calcium being the key word, continues to be the most challenging intervention. So what do you do? Okay, we already know for the last decade they've been getting more progressive. They're trying to fix the problem, and that they can go in and do PCI, which is percutaneous coronary interventions, going in and doing something like putting in a stent, doing a balloon, all those things that we're familiar with. Okay, but again, complex CAD is different. So there's more things going on ultimately. Then it goes into what is the purpose? We're trying to increase the patient's longevity, right? And so let's look down here. The key thing that I found and again, I was speed reading this. What they do is, let's see, part of this was not effective, but one of the things that they did was, this is one thing, in these lesions, scoring or cutting, putting in a drill. Think of rotor rootering. You know, if you get your sewer lines backed up and they rotor rooter, if you ever seen the ends that they use to do that, cutting and scoring is what they do to the inside of the pipes, to cutting and scoring the buildup. I happen to know all this stuff because my husband was a plumber for 20 years. That's what they've usually done. They use high pressure balloon angioplasty, but that's limited to its ability to modify calcified lesions. All right, they go in and rotor-rooter it out. Specifically, balloon dilation for eccentric calcium results in expansion bias towards blah, blah, blah. We don't need to know over there. Okay, now look at this. This is the paragraph that I wanted you to see in this one. Shockwave interventional or intravascular lithotripsy, IVL. You've probably never heard of this. And the reason is because it's new to the US. Is a novel device, meaning, you know, okay, it's new, and it works with calcified lesions. The technology gained European CE mark in May 2017 for coronary arteries. So it was approved for coronary arteries in Europe, this IVL treatment, which is interventional lithotripsy, okay? But it currently has US FDA approval only for calcified peripheral arteries. Now, that's different. In Europe, they can treat patients with for coronary arteries. That means all coronary arteries. But for us in the US, only since 2017 has it been approved for peripheral arteries. See how important it is to know your anatomy and the verbiage and the differences? Okay, so peripheral arteries only, which it gained in June of 2017. So it's just so new. It is an innovative approach for treating this particular blah, blah, blah. Okay, so then now it has how this all is done. Okay, now we're not going to spend a lot of time on this because I want to talk about some of the codes and things and what we got to do. But I want you to have this because you should now, for a little light reading, go in and read this, the technology behind it, shockwave clinical data. Now, again, you're taking all of this kind of with a grain of salt because some of this stuff you don't need to know. Honestly, you don't need to know the clinical data, all right? You're not a clinician. This doesn't pertain to you. However, the technology behind it does. How's it done? Because we need to know what facilities have the capability to do this type of procedure. Are you working in one or coding for one that has this capability? If you are, then you may see these in the near future for peripheral arteries and then coronary arteries, because now we know, right? So we're not to the technology behind it, real world cases. Again, this is going to be a little bit probably above our knowledge base. So, but if you want to read it, it gives you a scenario. Okay. And what you should take away from this, a 73-year-old gentleman with past medical history of hypertension, dyslipidemia, carotid artery atherosclerosis, presented with a typical stable anginal symptoms, and then it goes on and on and on to describe this patient and what they did. Okay, so this is the type of stuff you're going to see in the documentation for the procedures. And you need to know by looking at that, get familiar with this so that you can see the verbiage they use so that you can abstract the information you need to be able to code it properly. So again, you're just bringing your knowledge base up on the verbiage. Future prospects, you want to read that because you want to, again, see the verbiage, see what the outcomes are, and hey, is this something I'm going to have cross my desk? Okay, now it is interesting. I'm into this, but notice here, here's our baseline. See this little blockage right here? I don't know if this is big enough for you to see. It's like pinched. All right, now here's after the shock wave. Look how that's opened up. And then finally, when they did all the procedures, that particular vessel is back to normal, right? Isn't that interesting? Now, one of the things you'll notice, see how down here we have our major vessels, but you're not seeing all these tiny little vessels opened up and vascularized, right? Because there's a blockage. It's not getting, and now, wow, look how big and open all of this is. So I think that helps me because I'm a visual learner, and then I understand, okay, that's what they're doing. There's calcium and stuff built up here. They go in and do the shock wave and do the treatments that need to be done, and balloon and all this other stuff. Now, I don't know how they do it. They must capture the stones, the debris, and suck them out. I'm assuming that's what they do. That all being said, that is one site that I think you'll find very, very helpful to you and beneficial. So now let's go to the other site that I looked at. And let's see, I wanted to let you know this is the link. Again, students will have that. And then here's more links that I use for the research. So this is the next site that I found that was really helpful. Safety and feasibility of intravascular lithotripsy for treatment of below the knee arterial stenosis. Okay, peripheral is all we're allowed to use in the US. Okay, this is a 2018 study. Now, if you're not familiar with these particular formats of sites for the abstracts, what that's doing is that is for providers, for the doctors, they are taking these studies. This is the abstract, so they say, here is the scenario. This is what we want to study, and we did a study on, and this is what we found. So this is going to be a higher level than your training in most cases. But again, it's the verbiage that you're learning so that you can abstract at a higher level, right? Notice here, conclusion. So what is the first sentence? The purpose to evaluate the safety and feasibility, blah, 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 for calcified intrapopliteal stenosis using intravascular lithotripsy, IVL. And we already know that's brand new. They've only been doing it since 2017. And it has to be peripheral. So this infrapopliteal, which is around the kneecap. Okay. Here's a conclusion. So you can read all of this, but the early results of this pilot study, because that's why they do these abstracts, demonstrated that the calcified stenotic infrapopliteal arteries can be safely and successfully treated with IVL. Then here's our keywords for search engines and stuff like that. And then it goes through, and what these will do is they will give you patient scenarios for their study and how things were done. The study design, the device that they used, etc. So ultimately what they're doing is they're just educating the provider on these possibilities. Some of this, like I said, is you don't need to know, and some of it's very, very interesting to you as you learn about a new procedure. Okay, let's see. Plus, you can jump out and look at some of these other information, this informational stuff. Now, just a heads up on these things with abstracts, these sites that have abstracts. Some of them will let you look at like 5 abstracts, and then they cut you off. You have to be a member. Okay. Other times they'll be free, and you can look at them anytime you want. This particular one, PMC, is a Journal of Endovascular Therapy. This is how me personally, not only do I bring up my knowledge base for disease process, but also to develop case studies for students to code in unique scenarios and stuff like that. They have these type of things for nurses as well, but this is the documentation provider documentation that you're going to be coding off of. Now, it doesn't look exactly like this, but this is the verbiage they're going to use. So you need to know things like, what an IVL is, what femoral popliteal artery. If you don't know where that is, that you need to go find out, right? Okay. That being said, that was a great site, which I've notated here. And then I looked at this study, and I thought, why does this look odd? And this is the question that came in, and it threw me off. And I'll tell you why in just a minute, and maybe you see it. But this was 2018. A query came in, a question, and this was good. It said, we're looking for a procedure code for shockwave lithotripsy of coronary artery by balloon catheter. Documentation within the op note states coronary intervascular lithotripsy, catheter balloon inflates, and it says, can you please advise on how to code this procedure? And so then it tells us what they advise us to do, and they said the procedure for this is, which I'm not going to repeat, go look in the code block of 670. And I thought, that's not right, probably. And it says transluminal coronary angioplasty. And I was like, okay, but that's not a 670 code, I don't think. I can't, but I guess I'm thinking, I'm not into CPT as much. And then it dawns on me, wait a minute. Who is the NZCA? I've never heard of them. And what's the ACHI? Shouldn't they have said, CPT manual? And then I come over here and I looked and I thought, oh, wait a minute. ICD-10 AM, HCIA and stuff. Oh, wait a minute. This isn't the US. This is the Ministry of Health, which we don't use those terms for two places I've never heard of. Well, it's because it's New Zealand. It's Australia. All right. So when you come up here and look at the website, health.government.nz, New Zealand, which is their code set is the same one that Australia uses, which is AM. So we use ICD-10 CM, which is clinical modification. They use ICD-10 Australian modification or modified, and these others. So anyway, I thought, oh, okay. And they don't use the same DRG we do. They use AR DRGs, but they use it almost exactly like we do. But their code set is a little bit different. So these CPT codes or whatever is 671 isn't, and 670, the first three numbers, that isn't our code set. They don't use CPT, so anyway, that all being said, that made sense. But why is it helpful to us? Because they are telling you, go code it off transluminal coronary angioplasty. Well, we do that, right? Transluminal coronary angioplasty. Where are we going to find this lithotripsy code? You're not going to find it under lithotripsy because there's not a code for that. Now, if you know how they do this, okay, then it would make sense. Ultimately, they go and do a transluminal coronary angioplasty. Now, we can only do peripheral, but they get to do coronary. They get to do it all. So transluminal coronary angioplasty isn't going to be what we're going to want. We're going to want transluminal peripheral angioplasty. Okay. And since there is not a code for the lithotripsy, it's going to be either under some type of new technology, a new temporary code that it can be used for. But the fact is you're not going to find it. It's going to be under other. If there's anything that states other, it's not unspecified. So you're going to code out what they normally do. So they go in and they look around, they find the blockage. Okay, then they would go in and probably do the Roto-Rooter thing that we talked about. They would do the balloon dilation, and then they would do this shockwave lithotripsy. Okay, and I'm sure they like capture all of the debris and then just suck it out, probably vacuum it out through the cannula or tube that they use, right? So you're not going to get reimbursed for doing the lithotripsy. Now, is it approved? Yes, it's approved, but there's not a code for it. And you're only just seeing this being done because it was only allowed to be done by the FDA in 2017. Okay, so who's doing these procedures? Big hospitals, major coronary and cardiovascular units that have bought the equipment, and not just bought the equipment, went and had their providers trained in doing this. So to get trained in doing this, they either have to go over to Europe or have somebody from Europe come and train them to do it because they're already doing it, right? And they're just now talking about it. So you're not going to see this done very often, but it's already being done to the fact that they're coming in and asking CCO, hey, how do I do this coronary lithotripsy? How do we code it? Okay, that's the fun part. That's what's exciting. And that is what this is how you do the research and find out about this type of thing. All right, now I got something else to show you. This is not to help you with lithotripsy, but in my search, I found this amazing document by Cordis. Now, this was 2018, so it is not going to be the most current, and but it'll be a launching point for you. Whenever they've done the work and made a CPT made a fact sheet for you, you can create your own fact sheet off of this, or cheat sheet, whatever you want to call it. But what I liked about this, and I wanted to share you because you're a student, is they've got this divided up for you. Now, you're not going to care about the RVUs and how much the reimbursement and all that stuff is, technically, unless you're doing billing. Okay, but if you are doing, you need to start learning more codes about endovascular procedures. This is going to help you along the way, and it's going to help you make notes in your CPT manual. So they've got it divided up: non-selective and selective catheter placement for arterial. So here is your codes, and they've got these all the descriptions written out. Okay. And then I liked how then they went over here. If you're just doing diagnostic imaging arterial, here's your codes ranges. Okay. And the verbiage that you're going to be looking at all in one place. Non-selective and selective catheter placement venous. Now, I just thought of something you may not be aware of. Do you know the difference between non-selective and selective catheter placement? When they say that, what does that mean? If you don't know, you need to find out, okay? Because it's two separate types of procedures, okay? Now we're getting diagnostic imaging venous. So everything we can do to arteries, and then all of these same things we can do the veins. Diagnostic, remember, is different. That means we're going in and trying to determine what the problem is. It's diagnostic. But then when you're in there, you're going to go do something about it probably. Okay. Then we're getting into angiography, and this is the renal artery. All of these are based on anatomy. Okay. Very important that you understand that. Location. Then we got cardiovascular or cerebral vascular. So renal, of course, is going to be those major arteries that run off the your main it's not the superior vena cava and inferior vena cava, that's the veins. Your aorta, so your abdominal aorta branches off and feeds the kidneys, so we're going to be down in that area. But if you're doing cerebral vascular, that's hep here. Cerebral head, vascular, those veins, not carotid veins. Those are because carotid aren't veins, they're arteries. But this is cerebral vascular, okay? And then, but cerebral vascular is also meaning arteries too. So, okay, then we've got lower extremity interventions. This is where you're going to start seeing, because these are peripheral, right? So these are some of the things that'll be done that you might see this lithotripsy, carotid artery stent placement, angioplasty, uh, uh, erythrectomy, stenting in other vessels. And I'm just not going to read all of these. Vena cava filters, thrombolysis, and all this stuff. But this was a really, really great PDF that what I would like for you to do is, you don't necessarily need to print, but make your own tables if it's pertinent to you. Okay. Now, you don't need these MSDRGs. This is all billing stuff. Now, if you're doing billing, then hey, this is great for you to do that. I was looking at it, for the CPT, quick things on CPT, but look here. Hey, modifiers, some heads up about that, and PCS. Can't beat that. Inpatient procedures, a lot of these are PCS codes. And so it's telling you where to go and the root operation for these PCS. That's awesome. Okay, so I really fell in love with this particular document. It's a PDF. It's a fact sheet for 2018. I suspect they haven't made one for 2019, but maybe they have. I don't know. But this is by Cordis. Really love that. And I think you'll get a lot out of that as well. Okay, so if do we have any questions about what we've found so far? I guess I could bring over the this is look what I put in. Well, first of all, I put in lithotripsy and cardiovascular, and then this came up as an option, and I thought, no, that's what I want. Shockwave lithotripsy. So your keywords are going to be lithotripsy, coronary, and shockwave. You may not even be able to do, you may take out coronary and just do artery, but it would, for us, it's going to be peripheral, right, is ultimately the procedures want to look at. Notice here other options, that lithotripsy, coronary artery, lithoplasty procedure, you don't want that. Coronary intravascular, notice intravascular is inside the body. Most of the lithotripsy that was done for the kidneys and the biliary stuff, that's extracorporeal, that's outside the body, right? So we want intravascular. We're inside the vascular system when we're doing this. Okay, all right, so that's going to help you for keywords. Then look, how do they do them? So now Shockwave announces this FDA clearance 2016. So this video came out in 2016, September, and in 2017 it was approved for peripheral arteries. This is the same video, but different sources. Anyway, you should look at this one. This is 2018, and I bet this is a local. It says local 12 news, so somebody's done some type of advertisement for a new facility or for a facility that's doing this procedure in 2018. Okay, so those would be beneficial sites, things to go look at to bring up your knowledge base on how it's done. Right? This is exciting stuff, isn't it? Again, let me just rein it in here. Let me turn this off here and get to our last page. What you need to know, okay, as a student, is that you will be doing research as you're a student from this point on in your career. This is how you do that research. It would be a good idea. Don't get overwhelmed. Don't do that. But whenever you come across a term like, let's say, lithotripsy, and you're thinking, I don't really know what that is, and here I'm coding it or trying to pick the right code. I kind of know it has something to do with kidney stones, but this is how you do the process of doing research in some ways where you can bring up your knowledge base. Now, some of it's going to be way over your head, and don't let yourself be intimidated by that, because even if you pull out that one website that I did, and that's just full of big doctor speak, that's going to go way over your head, you may still be able to abstract some things and say, oh, I didn't realize that's what they called that. Oh, IVL is the new term. That's the abbreviation. Oh, I didn't realize that was the abbreviation that they used for doing lithotripsy of the kidneys. Okay, now I know that. So you can write that down, and that will help you in the the terminology section of the CPT exam, because they're not going to tell you. They may just say it's an EWL or whatever, right? And you're thinking, what was that again? Oh no, you can have that now. You can have that written down in somewhere in one of your manuals. It's like, oh yeah, that's what that is. And that's like taking something like end-stage renal disease. They're not going to say end-stage renal disease. They're going to abbreviate it because that's what everybody does. You have to know it's end-stage renal disease, ESRD. Right. So again, those are those little things that are going to make you better at coding and how you can build up that knowledge base. All right. It's fun stuff. Don't forget, at any time, if you have questions, just go to the club and ask those questions. Maybe you find something out there, or you want to share a video that you found of one of the procedures, or even just plain old angioplasty, that you thought was really helpful because the guy that was like recording over it and telling you what they did used great layman's verbiage, or something resonated with you. Share that so the other students can benefit from it as well. Again, you can ask questions there, and all of us will be there to help you out. And maybe you'll ask a question like this person did, and you'll learn something new that you didn't even realize was this procedure that was recently approved in the US. Okay, thank you guys. Have a great rest of your day.